થઈ ગયું ને?
જો જો આવ્યું નથી અહીંયા. આવી ગયું.
થઈ ગયું.
યસ. આવ્યું નથી. ડન. તો પછી
ડન ડન.
હું આવું 5 મિનિટમાં.
હા
તું જોઈ લે જરા, વેલકમ વેલકમ કરવું તો કરી દેજે.
હા, કરી દઈશ, વાંધો
એટલે
નહીં.
મોનિટરિંગ કરજે, બાકી બધું તો હું આવીશ પાછો. કારણ કે બધા ઇન્વાઇટ કરે છે, મારે આવવું પડશે. હું
હા
આવું
એટલે
છું.
હા, બરોબર છે.
આવું
ડન
આવું 9 9 માં 2 મિનિટ બાકી આવી જઈશ.
ડન. હા. અચ્છા.
Good evening. Good evening, Satish bhai.
Good evening. Good evening.
Sir, good evening.
Good evening, Dr. Jalil. Good evening, Dr. Pankaj. Thank you so much.
Welcome. Always a pleasure.
Hey, good evening, Vikrant.
नेट का कनेक्शन कौन सर नमस्ते सर देयर इज
Your voice is cracking.
नेट सर आई एम कनेक्टिंग विद इन 1 minute सर
Okay, no problem. Hi, Dr. Ashutosh.
कोड बच्चा
Manish, I have made you host.
Actually, my video is somehow not playing. I don't know why.
Is it?
Hmm.
Uh, I don't know. Everyone is working, I think.
Yeah, only my laptop has some issue probably.
Acha. No worries. I'm there.
I'll restart I'll make you host and I'll restart the thing.
ठीक है. Okay, no problem.
Chetanji, you please tell your current EB member to support us.
Yeah. Fine. This is on YouTube. You are live. चितकारा सर को बोला याद कराना पड़ेगा क्या? गुड इवनिंग प्रमोद सर. प्रमोद सर कभी वीडियो ऑन नहीं करते हैं.
गुड इवनिंग चेतन भाई.
गुड इवनिंग.
Bye. Good evening.
गुड इवनिंग सर जी.
So this will finish at around what time? 10:30?
10, it depends on you. Yeah, I was just thinking of Bala sir and he's there. Good evening, Bala sir.
Hi, Chetan, Satish,
Hi, sir. Good evening.
Raj, and Dr. Vikrant.
गुड इवनिंग सर जी.
Yeah, Pramod.
As per your instruction, wish and will, the panel is there in front of you, Bala sir.
No, it's all your master planning, man.
No, your guidance makes a huge difference. Next time onwards, sir, we are starting with your exams. You, the master blasters, will be appearing for exams.
What are you talking about?
Yes, sir. We have planned, sir. Me and Bhaskar Shenoy.
No problem.
It will be all spontaneous exams. So we have found a wonderful case series sort of things, and there will be presentation absolutely without any information sharing.
So that is not his exam. He cannot be.
He
Nobody
is
can.
examiner. He is examiner.
He will
Good
teach
evening,
us.
Bala sir. Good evening, sir.
Good evening, Jali. I want to be a student. I don't want to be an examiner.
चेतन सर नमस्कार. बाला सर नमस्कार.
Namaste,
सतीश सर
Pooja.
नमस्कार.
Namaste.
Yeah.
Namaste.
But if you become student, then who will become teacher? That will be an issue.
Actually, that's what I
Yes, sir,
tell
good evening.
my students. Yeah, every time you take a PG class, these fellows would have read so much that you can actually learn from them.
Sir, but that's only knowledge.
Correct.
Your
Correct.
wisdom they cannot replicate.
Correct. Yes, big boss.
Hello,
Chitkara sir,
good
welcome.
evening.
Chitkara
Good
ji,
evening,
good
sir.
evening.
Good evening.
Sir, namaskar.
Good evening, sir.
Let me check my share the desktop. Okay.
Yes, sir.
So
Yes,
if
sir.
it doesn't work, then probably I'll change my system.
Yes, sir.
Okay, so share. Stop. आप करो बात करो. In the meantime, let me see if I can share. Okay.
Chetan, permit him to share the slide and see if everything is okay.
Pardon?
Allow Chitkara to share.
Already, it is allowed.
No, ask him to check.
Yeah, but
Yeah,
Chitkara
that
sir.
is what
Chitkara ji,
I'm
yes.
doing.
Please check.
That is,
Please check.
sir. Yeah, that is what doing, so that we start right as and when it is there.
Good evening,
Good evening,
Dr. Maduro.
Darur sir.
Yes, good evening. Good evening. Just I'm trying to check.
Good evening, Daru sir. Good evening, Dr. Jalil from Coimbatore.
Oh, sir.
Good evening, sir.
Good evening. Very, very good evening, sir.
Where is Bhaskar? Must be still in his clinic.
Sir is joining.
Yeah.
Bhaskar sir is joining.
Yeah. Chitkara sir, are you able to share the screen?
That is what I'm trying. 1 minute, it is downloading.
Okay.
Good evening, sir. Sir, good evening.
Good evening, sir. Good
Hey,
evening.
Bhaskar.
Yeah, Bhaskar has come.
Hi.
Dr. Bhaskar.
Chairperson, namaskar, chairperson.
President, sir, please come.
Namaste.
Chairperson, sir.
Sir, namaskar, sir.
Namaste.
Pandya, sir. Dr. Pankaj Deshpande. Daruru, sir. Namaskara.
Namaste.
Namaskara is Kannada. Namaste is
He's
Hyderabad.
Gujarati.
So today, tough examination is there, I think, for Pandya and
No, sir is very lenient. Chitkara, sir.
Is my screen visible now?
It is, but
Yeah,
there is nothing. Yeah. Now
yeah,
your
yeah. You just
iPad is.
choose your PowerPoint. Yeah.
Just 2 minutes, it is downloading.
Okay, sir. But we are able to see it. So no problem.
Okay.
It's from an iPad, is it?
Yeah, it's from an iPad. My somehow my personal computer just
Yeah.
went flop right now. So I was trying. That's why I'm late. Otherwise, I would have logged in
Yeah.
15 minutes early.
Chitkara sir, can you stop sharing? By that time we can just, because
Sir, that is the main problem. Just give me 2 minutes because
okay,
if
no,
it
no.
doesn't,
Acha,
if
it gets downloaded, no? Okay.
yeah,
It
if
is
it
your
doesn't, yeah.
screen is okay, okay. Got
Is
it,
it
got it.
okay now?
Yeah.
Yeah.
Okay, so
Make it a full screen.
no, just let me see. It is full screen. Yeah. Is it okay
Slideshow.
now?
Slideshow.
Yeah.
Yeah,
Fine.
yeah.
Yes.
Great.
Okay. So yes, now I can stop sharing, and when you guys tell me
Yes.
to share, I would do it. Okay.
Fine, fine.
So stop share.
Thank you. Thank you.
Okay now.
Yeah. It's nine
Yes,
o'clock.
sir.
I think we can start.
Yes, yes.
Yeah.
So,
Just
good evening.
just give me 1 minute, please.
Okay. Ready,
Yes, sir.
sir? Okay, Manish, you can start. Yeah.
Yeah. So, good evening, everyone. Welcome to yet another episode of Link 13 of Super 11 PIDA. And today's topic is urinary tract infection, problems and solution. Because nowadays we have seen lot many cases of acute pyelonephritis and urinary tract infection in infants. In our practice, we don't know the reason probably why it has increased, but maybe detection has increased, or maybe use of diapers or lifestyle changes would have been the reason for increase. These all questions are going to be solved in today's session. And for that, before we start, I request our President Chairman Dr. Bhaskar Shinoy sir, 2025 PIDA, to share a few words and welcome everyone.
Good evening, respected Dr. Bala, Dr. Daruru, Dr. Chitkara, and all the esteemed panelists, and my secretary, Dr. Chetan, Manish, Vikrant, Pankaj, and all the faculties, Dr. Satish Pandya. And it is a privilege to have you all for this evening program. It's a wonderful program and will be moderated by none other than Dr. Chitkara, who is our Sachin Tendulkar of our ID chapter. Always he scores centuries. So with that, I don't want to stand in between the discussion and this thing. But in fact, urinary tract infection is a problem which looks very simple. But when you go deep into that, there are a lot of controversies. Whether to how to do the cultures, how to collect the samples, then a lot of things like when to start antibiotics, when to investigate in a case of urinary tract infection. Should I give prophylaxis? The guidelines have changed. There have been a lot of controversy. So to clear these confusions, none other than Dr. Chitkara, we have as a moderator, and the esteemed panelists, Dr. Satish, Dr. Vikrant, and Dr. Pankaj, will definitely clear the cobweb and throw some light on the clarity of the situation. Thank you so much for joining today. And I hand over to Manish for further proceedings.
Yeah. Now I request PIDA Secretary Dr. Chetan Trivedi sir to say a few words.
Yeah. Good evening, friends. At the outset, welcome me all of you for this another link of Super 11, which is the brainchild of Dr. Bala Subramanian sir, and it was started under the like chairmanship of Dr. Ravnath Darur sir, and it has been picking up very nicely. Everybody is appreciating, and that's why we are trying to keep the topics of general pediatricians' interest. And here, once again, we have a topic which is really very common, but still, once this discussion unfolds, we'll be knowing that how tricky the situation and the discussion can be of a simple topic. So we are looking forward for a wonderful discussion from Dr. Chitkara sir, journalist Dr. Satish Pandya, Dr. Vikrant, and specialist and pediatric nephrologist Dr. Pankaj Deshpande. Special thanks to Dr. Deshpande. He specifically postponed his meeting or something was already planned just at the request of Dr. Chitkara sir and Bala sir, which I took two names. So he just changed and he's been here. Thank you so very much. And looking forward to fantastic discussion. Thank you so much.
In fact, I remember Dr. Pankaj had written a beautiful article in our journal about the controversies in the urinary tract infection.
I will be mentioning
you have a right choice here.
I will be mentioning it. Yes.
Yes, over to Manish.
Yeah. So without wasting a minute, in presence of some experts of ID, Dr. Shyam Kukreja sir, Dr. Bala sir, Dr. Rangnath Daru sir, and Dr. Pramod Kulkarni sir, we'll start the session. I request our moderator of today's session, Dr. A.J. Chitkara sir, to start the proceeding, sir.
Okay. So good evening, everybody, and let me share my screen before I start my talk. So screen, Zoom, start. Is my screen visible, please?
It will be in a moment.
Okay.
It is seen, but you're not able to. Yeah, maybe in a moment. It is showing Dr. Chitkara has started screen sharing.
If it is not, then I'll probably reload it.
It is not visible yet. Going further. I think initially you shared your iPad only directly.
Is it visible?
No, no.
Yes, sir. Not yet.
Okay or no?
Yes, sir. Done.
Done.
Yes, sir.
Okay. So good evening.
Make it full screen. Yeah.
It is
Yeah,
full
it is.
screen now.
It is.
Okay. It's readable. Everything okay now?
Yes, sir.
Okay. So like Bhaskar said, UTI is actually a very simple disease. And why we say this is because symptoms and signs are very typical, except in the very young, I would say infants. And we know there is a single organ system which is involved. The investigations required are really very few, and there is a hierarchy as to what you start with and where you end with. The bugs are limited, and 90% is E. coli. There are some other Enterobacteriaceae which may uncommonly cause UTI and sometimes other organisms which we will be discussing. Now, again, the treatment is a limited choice, just a few drugs, which are the recommendation. But what makes it stand out is the complications and the chronicity of the disease if you miss a diagnosis of UTI, especially in a young child. This is what makes UTI a very complex disease. So always remember that UTI in a child is just a kind of an opportunity or a sentinel event to diagnose underlying urogenital abnormalities or what we call as a bladder bowel dysfunction, which basically because of a constipation which is almost rampant. I would say there is an epidemic of constipation, especially in North India, of the patients I see because of their dietary issues. So the moral of the story is that while UTI is a very simple disease, we don't miss it, because if we miss it, the patient suffers. And at the same time, we should be very careful not to overdiagnose. And these are clinical practice points which we would be discussing in the further slides. So therefore, it is not surprising that almost last 2 decades, there have been all, sorts of organizations or voluntary associations or scientific bodies giving guidelines on UTI. And when we all the time say it is a simple disease, and the latest being our Indian Pediatrics Nephrology Group, which is in 2023 and published in 2024 in Indian Pediatrics. What has changed in 2 decades? It is earlier we had, aggressive treatment, very extensive imaging exercises, and long-term chemoprophylaxis, and a kind of an early resort to surgical correction. And what has changed over the years? It has narrowed down or zeroed down to a short duration of chemoprophylaxis, avoiding radiation exposure because of multiple investigations when we, suggest them indiscreetly. The procedures, invasive procedures, are now limited, and we just have a judicious management of UTI. The ultimate goal is to preserve renal health so that they don't go into chronic kidney disease or the complications. Now, with this background information, let's start with our panelists. So, Dr. Satish,
Yes.
when do we miss UTI?
So, as you said, it is very common, but still, because of the manifestations which are different at different age groups, it's often difficult to know. I mean, it's very often that people miss UTI in young infants, especially newborns, children below 2 months of age or below 2 years of age, because they cannot verbalize the complaints. Like say in older children, you get complaints of dysuria, increased frequency, etc. But in younger kids, it may manifest in a different way. Like say for a newborn, it could be very non-specific symptomatology like lethargy, poor sucking. Child may present with septicemia, child may present with seizure, child may present with high-grade fever. So these are various manifestations that we see in a neonate or infant, below 2 months of age. Little older children will present with little more specific symptoms like, yes, up to 2 years, there may not be many specific symptoms, but they may present with fever without focus. I mean, whenever I see a child with fever without focus in this age group, now I must ask for a urine examination if I am not able to see anything clinically. Then they may present with parenteral diarrhea or vomiting or abdominal pain also. And of course, in immunocompromised kid, you need to have a very high index of suspicion. Now, above these 2 years of age, it's very evident because child will complain of dysuria, difficulty in passing urine or pain during micturition, interrupted stream, dribbling or urine. All those things will point to a diagnosis, whereas this younger children is a specific group where we are very likely to miss, and we need to have a very high index of suspicion for that.
Okay, so I think it is a well answered question. It is the age which matters because the symptoms and signs are not very specific and there is no clue towards the urinary urogenital system. And second major group is immunocompromised, when again the symptoms may be quite atypical. So, Dr. Prusti, diagnosing UTI. How do we diagnose UTI in clinical practice?
Namaskar, good evening to all. So as rightly Chitkara sir, as you mentioned that yes, the symptomatology is very important because we often diagnose by the blood test. So very important thing is about the symptomatology. So in the background of a clinical context of UTI, so maybe fever, maybe dysuria, burning micturition, urgency. So these things may be missed in children less than 2 years of age group. But if there is a fever without focus or in children more than 2 years of age with the symptomatology of UTI, along with that, any laboratory evidence of urine infections, that might be a screening test with that of leukocyte esterase test or nitrite reductase test or urinary gram stain. Along with that, the gold standard is urinary culture. If a single specimen of urine culture shows a single specimen of growth as per the source of collection, if it is suprapubic, more than 10 to the power 3 colonies, or if in case of a catheterized sample,
Dr. Prusty will be coming to that urine evaluation in detail. So what you tell us is one symptomatology, especially a febrile child with symptoms pertaining to urinary tract, especially in children more than 2 years, and urine evaluation is actually a must, and a single pathogen urine culture positive is a gold standard. So Dr. Pankaj, we have defined a UTI, febrile child, that means fever is must. Urinary symptoms, children more than 2 years, a positive urine culture for a single uropathogen. So with this kind of definition, what do you think pediatricians or generalists are overdiagnosing UTI?
Okay, how much time do we have to talk about this?
So
A few
I know
minutes.
you have divergent opinions.
Right.
I am told.
Let's start with the very first point that you said. Urine collection. When do we do it in a
No,
child?
Pankaj, we'll be coming to all these
No, I
finer
know.
details.
I'm answering this
Yeah,
question
yeah,
itself.
yeah.
Based
Okay,
on this.
okay, go on. Yeah,
When do we
yeah, please.
overdiagnose? So my basic point is, when do we send a urine test? We send a urine test when we suspect a urine infection. When do we suspect a urine infection? If you have fever without focus or urinary symptoms, irrespective of the age of the child. Now, in these two, let's forget about urinary symptoms. As you said, you'll probably talk about it later. Fever without focus is what we talk about for infants. Now, just as a ballpark figure, I want to ask the audience here, if you take 100 children having fever without focus, what is the incidence of urinary tract infections? Any idea?
So I don't think people have a kind of a link to a
So, okay,
faculty
let me answer
panel.
it. So
Yeah,
the
you
point
answer.
is that there are multiple studies, including from Indian emergency rooms, which show that the incidence of UTI in a child having fever without focus is not more than 5 to 10%. The way we are going about it, we are calling nearly 50% of them as having urine infections. I think that's where we need to understand where the problem lies. For example, the single pertinent point none of the guidelines are telling you about, in a fever without focus, when do you send the urine sample? At 24 hours, 48 hours, or 72 hours? And in a child where the fever has gone away, do we still call it a UTI or don't call it a UTI? These are very complex issues. There are very simple answers, but that's a different talk altogether. But my point being that let us understand that fever without focus does not automatically mean a urine infection. 90% of the times it's still a viral infection. So when you collect urine, you need to make sure that you're doing it in a right patient. As Dr. Kruti mentioned before, the symptoms that suggest a urine infection. So if you have urinary symptoms and fever, it's simple. But if you have only fever without focus, in fact, American guidelines would say that if you, and none of our guidelines unfortunately differentiate this, if you have a well child or a sick child, we never differentiate. And in your practice, in your clinical practice, you do it all the time. You look at a child and you realize, well, this is a sick child, this is a well child. So even in the American guidelines tell you that in a well child, you are allowed to follow up the child without even doing a urine test till the fever goes away or till you feel that it may be a urine infection. So I think the first thing is the criteria that we select to decide when to do a urine test is important. The second thing we need to understand is pus cells is not equal to urine infection. Significant pyuria can occur in many conditions, including in simple fever, including in dehydration, interstitial nephritis, glomerulonephritis,
So I'll Pankaj, I'll be coming to each of these points what you are saying. So my
Right.
simple question is, do you think general pediatricians or family physicians are overdiagnosing UTI or no?
Yes, many times.
They are.
Many
Okay.
times.
So
Sir, can I add? Sir, can I add?
Yeah.
yes, please.
This so-called overdiagnosis of UTI is only based on urine examination. Most often what we see even in pediatrician is that urine culture is not practiced as much as it should be, and only leukocyturia is labeled as UTI and treated accordingly. That's the point.
Okay, so Satish, as a general pediatrician myself, I would always correlate clinically.
Yes.
Like Pankaj said, I would suspect based on the clinical symptomatology below 2 years or above 2 years, so fever without focus or with urinary symptoms, and then probably I'll go with the immediate urine screening. Okay. So
Right.
Pankaj, many patients come to, so Pankaj absolutely agreed that UTI is overdiagnosed. Now many patients come with the doctor foul smelling urine. What do we do? Is bad odor a correlation for UTI?
Absolutely not. It
Absolutely.
depends on what the child is having as food. For example, children who have eaten eggs tend to have a very bad smell of the urine the next day. So a bad urine is not equal to a urine infection unless there are other symptoms that are present.
Okay. So now there are issues with the urine evaluation, whether it is the collection, whether dipsticks, pyuria and bacteriuria, which you referred. So I'm going to take each one individually. So therefore, the first and foremost is collection of urine sample, Pankaj.
Yeah.
Well, how do you practice more of pediatric nephrology? How do you tell your patients who are not toilet trained to collect a urine?
Correct. There are 5 things that every pediatrician has to know when you ask for a urine sample. So the first, we have already talked about up till now many times, symptoms. Only when the symptoms are present does a urine test make sense. If the child is asymptomatic and you collect urine and it shows a culture positive or 100%, it's normal. Okay, so the first is the symptoms have to be present. The second, the genital area has to be clean with normal soap and water. Then in a child, as you said, in an infant, a clean catch urine is good enough. In an older child, you want a midstream sample, which is extremely difficult even in an adult. Bag urines are a complete no. You need to make sure that the urine sample reaches the lab within 30 to 60 minutes. And in girls, you have to make sure there is no vulval redness when you collect the urine sample, because you will get all your reports abnormal if there is vulval redness. So these 5 things have to be followed. So as it rightly says there, bag collection is a strict no. Clean catch specimen, or if it's an older child, you can do a midstream sample.
Okay, so this clean catch is a very troublesome issue, especially in, as I mentioned, non-toilet trained children or below 2.5 or 3 years. We suspect UTI, tell them to go give a urine sample for examination, and for next 24, 48 hours, they are not able to collect. It looks very, very good when you see these photographs, and especially with a girl child, where they would never see the bottle which is kept so far off. The girl child is never going to pass urine in a stream. So I do not know all these clean catch or voiding stimulation, because invariably it would trickle down the vulval region. So what do we do? Practical aspect, Pankaj.
The guidelines will tell you can catheterize or do a suprapubic. Between the
Forget
two,
about guidelines in your practice, because guidelines tell me clean catch, MSU. I don't know how to collect that, and there is a delay of 1 to 2 days. So as a pediatric nephrologist, what do you tell them? Practical issue.
No. So I think there are 2 issues here. The first thing is a urine routine. The second is a urine culture. Correct? So a urine routine, even if it trickles down and you collect it, it's not going to make a difference to your examination. So if it shows significant pyuria, you can then collect the urine sample for a culture, collect it, and then start antibiotics. You don't need to wait for the culture to come back.
Okay,
Yes, I understand
Satish and Dr. Prusty, what about your practical experience in a clinic collecting urine?
It's a big challenge usually when we ask the parents, in an infant especially, leave aside untoilet trained older children, infants less than 1 year of age, when we ask the parents to get urine examination done. Their first question is, how do we collect? So I think our onus is to educate, counsel them as to how to collect it. So cleaning and all that is done. Position of the patient is also important, and some form of stimulation does help, sir. I do practice this stimulation that after feeding the child, say about 30 minutes or so after, you little bit either rub on the suprapubic area or you gently tap it, and usually we get it. I mean, in my practice, because I'm not doing any intensive care, I have not yet resorted to any catheterization or suprapubic puncture so far. So it usually is, I mean, it's difficult. It may take some time, maybe few hours sometimes, but we are able to get the urine sample.
Okay, Dr. Birender, is that okay,
One
Birender or Dr.
Vikrant,
Prushan?
sir.
Huh?
Vikrant, sir. Dr. Vikrant, sir.
Okay, Vikrant.
Sir,
Practical problems.
reality is that yes, matlab, yesterday one mother came. Sir, you have written 4 times for the urine symptoms, sir. Every time I come everything without a urine report because it is very difficult to collect. In that clinical context, sir, it is wise enough to go ahead with a back collection, sir. I will rather personally tell that it will rule out whether a urine infection is there or not. If you get a positive result, you may not be pretty sure of that, but it rules out. If you get a urine culture negative on that black collection, it has got a good negative predictive value that rules out UTI. So in that clinical context, yes, back collection, if the parent is not able to do, yes, can go ahead with the back collection with a good negative predictive value. If you get a negative results, that almost rules out the UTI. So that can be an additional point. And second thing is about, as Satish Pandya has told, yes, stimulation and all are, yes, possible, but it's always in a reality, it's a difficult scenario. Baki rest things, after 2 years, 3 years in a toilet trained child, yes, it's good enough to get a clean catch mid urine sample, that's fine.
Okay, so Pankaj, Dr. Vikrant has opened a Pandora's box. Back collection in your practice and catheterization in your practice. How often do you do it when the patient says they are not able to collect urine for 24, 48 hours?
As Dr. Satish said, I've never come across where the child hasn't been able to give a urine sample. You will get a urine sample, you have to just be patient. We have never resorted to back samples, and I have personally never advised catheterization for a sample.
Okay, so
Can I
while
Sir,
we all discourage back collection because of these issues, because of a contamination or a false positive rate, Vikrant is sometimes right. It becomes really very difficult. So a negative back collected urine is a very good kind of a predictor whether UTI is there or not. My audience as well as my panelists may not agree with me when it comes to writing a guideline or showing a slide. But this is what our personal experiences and probably personal experiences in today's date in evidence-based medicine has no value. So evaluate individually. But what message I would like to give is, like Pankaj pointed out, local cleaning is the most important before sample collection. And that is where we falter, and there are many fictitious UTI. We keeps on, being on antibiotics for no rhyme and reason. And even started when the fever has already come down. So I wonder why UTI diagnosis and why this. Do you agree, Pankaj?
Yes.
Okay. So now again, Pankaj, we have given a urine sample, and there are certain laid down criteria by all guidelines which have been issued. Do you agree with these guidelines, or you have a little divergent?
I think it is the most important thing is the symptoms of the child. The urine collection comes second. In the freshly voided sample, it has to reach the lab within 30 to 60 minutes. That's fine. It has to be plated within 1 hour. 4 hours is a bit too long. Any urine sample left in room temperature for more than 1 hour is more likely to have contaminants. So
okay, I ask you a question. Most of the big labs or multinational labs have collection agencies spread across the cities. You deposit a sample there as fresh as possible, and it reaches where it is tested about 10 hours later, or maybe you give it in the morning and reaches evening. What do we do about it?
So that is where the misdiagnosis or overdiagnosis of UTI happens.
Okay, so
I think it has to be told
Satish and
that it has
Vikrant.
to be, yeah.
Satish, is
Sir,
this
in
a
my
practical
practice,
problem?
yes. In
I
my
would add-
practice, it's not a problem because we have in my own setup a collection center, and from collection center to the central laboratory, it goes in an ice box that I have personally supervised, that all samples are put in a sort of ice box and it reaches there within 30 minutes or so. So I don't have.
Satish, you are a privileged pediatrician. What about my colleagues who practice in far-flung areas and rely on collection centers of various labs which are far off?
Sir, the urine routine examination is not a very difficult thing. So I think pediatricians should insist upon the laboratories to make an arrangement so that no sample reaches in time. There should not
Okay,
be a compulsion
Vikrant,
to wait for 8-10 hours.
yeah, Vikrant,
So
how often do you get a fresh sample for
yes,
examination?
sir. Very true. When it comes to a clinical scenario in a reality, for example, you collect a sample at 7 o'clock in the morning and the pathologist is going to come at 10 o'clock. So there is no point in giving it. So one thing we can add to that is that we will insist the parents to tell the labs, if you are not doing a fresh examination, just keep the sample inside a refrigerator. So that will add to the value to the urinary examination along with that of culture. As you are very much aware of that. So when it comes to a contaminant samples like urine, which has high chances of growth of contaminants, you need to refrigerate sample. For example, if you are collecting a blood sample, you do not need to refrigerate because these are sterile samples. So for urine examination, if it is being delayed beyond 1 hour, okay, I will rather advise the lab people or the parents to refrigerate that sample in less than 4 degrees Celsius for till the urine sample goes into examination, the practical scenario.
Well, we say all this, which is very easy when we say it in webinars or on the dice. But if the mother is able to collect a urine at night, no lab is open, no collection center is there. And probably they would be wary of keeping it in the fridge. It looks very simple when we talk of a simple urine examination, but these practical difficulties are really happening. And that is why we probably either miss or we overdiagnose. So, Pankaj, what about the
Sir, I want
gram
to add
stain?
something, sir, please. I
Yeah,
want to add that when you have a sample, I mean, reported as positive or negative, and if you have very high clinical suspicion, you can redo it and you can inquire as to how the sample was collected and how much time it took to the laboratory. So I think that's cross-check from our side as a clinician should also help.
how does that help the patient, by the way?
Sir, it will help that we will not misinterpret the laboratory report.
Okay, Pankaj, there are laid criteria and their sensitivities and specificities, and there is a confusion whether you should be doing dipstick or not. Staining of a smear or seeing it for bacteriuria is probably no urine sample. I find a report which is done like this or bacteriuria detected and dipsticks. Pankaj, your opinion?
I think out of all this, the simple one that you can look at is pyuria. So we know what is significant pyuria. It is more than 5, as you have written there, more than 5 white cells per high power field in a centrifuge sample, or more than 10 in an uncentrifuged sample per cubic millimeter. Now, urine microscopy for gram stain, the most confusing part is a parent will come and show you a report showing bacteria positive, everything else is negative. And that is because it has, as we talked about, the sample has reached late. And so it's a growth of contaminant organism. So unless the child has symptoms that are suggestive of a UTI and you've got other correlating factors, that is not a proper gram stain. Gram stain has to be done immediately when a urine sample is taken. And then if you find something, then it'll be uh, possible to say that it is possibly a urine infection. Now, as we just
What about Le and nitrite, which is always done by a
I'm coming to
dipstick?
that.
No one does it biochemically.
Yeah, so I'm coming to that. So dipstick, you need to know there are false positives, false negatives also. So we all focus upon the specificity and sensitivity trends that are given. So if you've got a dipstick positive, as you said, nitrite positive and leukocyte positive, it's a UTI. No, it isn't. Because if the lab does it 4 hours after you have given the sample, unless you do it in your clinic yourself, you cannot rely on that. So you often have reports where the urine routine is bang normal, but the nitrite is positive. And we don't call it a urine infection. It's simply because the sample was checked late. Secondly, if you are using the dipstick to find out nitrite leukocyte, if you keep on opening it and leave the sticks exposed to air within 2 weeks, 50% of the sticks will start reading positive. So you need to be careful about closing the lid. And then certain agents, medical agents, interfere with this, and therefore you'll get a positive nitrite test. So all these are not 100% certain. The second most important thing which we need to understand, unfortunately, it's slightly beyond the scope of this, is the fact that when we say nitrate is positive, what are we saying? We are not equating it with UTI. We are saying there are significant number of organisms in the bladder. Now, whether the significant number of organisms in the bladder is equal to a urine infection is a clinical decision. For the simple reason that, again, go back to your American guidelines. What are they saying? They are saying that infants, we just talked about all this, 0.7% of infants have 3 positive urine cultures done several weeks apart with absolutely no evidence of urine infection. So what we
Okay,
are
so
why
may I tell you that I am a person who is born in India, made in India, and everything in India. So these American and European and Italian guides really don't impress me. I only go by my Indian guidelines. But you have perfectly answered that only Le nitrite positive does not mean UTI, but
no,
Le plus nitrite plus.
my point was not about American guidelines. My point was
Yeah.
1% of the population carries bacteria, and which is why your definition of a UTI even in suprapubic has changed. It used to be any organism. Now you're saying 1,000 organisms.
Yeah.
So the point being that a lot of children have a culture positive even when they are completely asymptomatic.
Yeah, so
Which
only
is positive.
leukocyturia or only Le or nitrite positive by a dipstick is not a good evidence for UTI, but however, both together combined is a good test with a good sensitivity and specificity. So urine culture, Dr. Satish.
Yes.
So urine culture, there are various guidelines, and the recent guideline ISPM has just a little change. So just your comments on this.
Sir, I am not actually in a place to comment on this guideline because I've been a general pediatrician and following all the guidelines as they come. But what I realized that I have gone through all the guidelines, 27 pages guideline of ISPN, and they have robust evidence to suggest this thing. That earlier, this recommendation of 10 raised to 5 was a very age-old kind of recommendation, a 60-year-old recommendation, I think. So now the studies have indicated that you are likely to underdiagnose or miss some cases of UTI. That is why they have lowered the threshold from 10 raised to 5 to 10 raised to 4 to 5 for clean catch, and the catheter is 10 raised to 3, and I think for catheter, the suprapubic it is 10 raised to 2, 10 raised to 1, I think.
Or any number.
So 10 raised to 3.
If I get 50,000 or let's say 10,000 colonies, is that significant in suprapubic?
With this new guideline, it becomes significant because it is 10 raised to 4 to 5 for clean cast sample. So then I think we have to reconsider. I mean, so far we have been following the earlier guidelines. For last year or so now these guidelines have come. So I did revise my own management strategies.
So Pankaj, international guidelines which you refer to have different kind of a categorization. Any comment on this?
So I think these are perfectly justified. 10 raised to 4, 10 raised to 5. Catheterized sample is 10,000 colony forming units. 10 raised to
Suprapubic aspiration.
suprapubic aspiration, it was any number. Now the practice guidelines say 10 raised to 3. So there is a bit of confusion. I think if you get any growth on suprapubic with symptoms suggestive of a urine infection, it is significant.
So that just defies logic. In a suprapubic aspiration, why should I give a number of 50,000 or more than 10 raised to the power 3 when I expect that the urine in bladder should be sterile? Is that right statement?
Yes, but unfortunately, that's no longer true. If you read microbiome studies have shown that bladder is no longer considered sterile, which is why I was telling you about 1% of the population having positive urine cultures all the time. So that's what I'm trying to say. So anyway, forget that any growth in suprapubic aspirate in a symptomatic child is significant.
So, Dr. Bikrant, what
Yes,
about
sir.
your experience with urine culture pathogens in your practice?
Yes, I do agree on this background with Pankaj sir that yes, in a clinical context of symptomatology of UTI with any culture grown on suprapubic, yes, we can consider this and treat this because as you are very much aware that yes, suprapubic is an invasive thing and very importantly you are getting some matlab growth. Yes, the number can be different, maybe any growth or maybe 1000 colony forming units, but in a symptomatology of UTI, you don't find any other focus other than that. Yes, better to go ahead with a treatment because you never know what is going to be there in the next.
What about the uropathogens? Do
Yes,
you
sir.
get
Very
frequently E. coli or you get non-E. coli UTIs more in your medical college?
Yes, sir. In medical college, sir, we are getting lot of non-E. coli pathogens too right now. We have got some cases of Eikenella kingella. We have got some cases of Enterobacter, but we do not treat all these cases unless we get some urinary symptoms. So if the child is responding to anything, something like that, the child is having some respiratory tract infection, because as a protocol of investigating the child, for example, pneumonia, we do send sometimes urine REME with culture, and we do get sometimes urine REME and culture of non-E. coli variants. So in that clinical context, if there is no symptomatology of UTI, we don't treat right away that patients if the child is improving.
Okay, so Pankaj, coming back to you, is Enterococcus or Enterobacter really a uropathogen or is it a poor collection? Pankaj,
Again, the symptoms matter. So if you have a
UTI,
symptomatic child,
clinically UTI, symptoms is
then it
suggest
is
sign
significant.
symptom UTI.
Then it is significant.
Immunocompetent from a community.
Now, we do find occasionally Enterobacter being present in the urine infections. So you have to consider it to be significant. So if you have symptoms of a UTI and a culture grown, you can't ignore it. You can't say it is just contamination.
Okay, so agreed. Satish, any take on this? Enterococcus,
Only
Enterobacter in
when there is
clinical
a
practice.
non-E. coli no organism isolated, I am little worried and no, I am looking. I look forward to some other anomalies like acute, etc., as you already mentioned in the slide. But usually in my
Okay.
practice, I am getting more of E. coli and not many non-E.
Yeah.
coli.
So most of us do get E. coli, but however, these enterobacteriaceae can be a cause, number one. Were rightly said by my panelists that there has to be a clinical correlation where you suspect UTI based on a febrile child and urinary tract symptoms or else fever without focus in younger children. Now, invariably, if you get other organisms like Pseudomonas, group B strap, staph aureus, these could be there rarely, but then invariably they are there if you have a urogenital abnormalities, especially obstructive, or an instrumentation or catheterization or a recent antibiotic treatment. So, based on our discussion till now, I think very rightly pointed out my panelist, bad odor in a urine is a poor predictor of UTI. The local area cleaning is a must because all these infections in the vicinity or a poor hygiene in the vicinity, especially vulvovaginitis, balanoposthitis, these would give rise to leukocyturia, sterile pyuria, where you don't have an associated correlating clinical symptoms. You really don't treat only leukocyturia, and there are various reasons. Even intra-abdominal infections, which are other than urogenital systems, can give you leukocyturia. You see bacteria without symptoms, there are no fever, nothing, you don't treat it or you don't diagnose UTI, and improper urine collection, we have devoted much time to this, is a major pitfall where it is overdiagnosed or sometimes a kind of a missed. Now, this management of UTI is adapted from 2023 guidelines, and I don't need to go into the details of this, except there are certain issues to be discussed. Satish,
Yes.
antibiotics, empirical or wait for culture report?
Again, I will go by clinical setting and my urine microscopy report. If child is symptomatic or a child, infant who is having high grade fever without other focus and if showing leukocyturia, I will not wait for the culture report. I will start an empirical no antibiotic.
Vikrant,
One thing to add to Satish said that in a background of a age of the child less than one year or 6 months, yes, we will not wait. We will go ahead with the antibiotic. But for example, if the child is symptomatic, means doesn't mean to only the urgency, frequency, and all. If the child is a febrile UTI, yes, if you delay the start of the treatment, each day delay in the progression of start of antibiotic has got extra risk, maybe around 5 to 6% of renal scarring. So in a context of a febrile UTI child in more than 2 years, or in a context of a child less than 6 months of age group, yes, we will go ahead directly with a antibiotic empirically without waiting for the culture. But for example, in a
Pankaj, do
case,
you agree?
So I think my first valid point was if you're sending a urine sample in a child having urinary symptoms, it's very clear. So if your microscopy shows evidence of pyuria, you send a culture of and start antibiotics, empirical antibiotics. If it is a child having
Okay, so
fever without focus, then you differentiate between a well child and a sick child.
one thing to ask my panelist, for example, a child with only dysuria and urgency, but the child is not febrile in a child of more than 2 years. Shall we wait till the culture report or we will go ahead with empirical antibiotic?
You start an empirical antibiotic.
Why?
okay. So I think the consensus is that you don't wait for culture reports, especially in younger children or when there is a clinical correlation. You seriously UTI with urinary symptoms in an older child and with a fever without focus, with no other alternative diagnosis. You treat UTI empirically and you don't wait for culture. However, remember, if the culture is negative, we have no proof, then remember always to de-escalate the treatment or stop antibiotics if by that time you have come out with a diagnosis or an alternative diagnosis. Satish, oral.
So it again depends on the clinical setting. Most often we do well with oral antibiotics only. But if a child
Yeah,
is very
antibiotics.
sick, vomiting, dehydrated, toxic looking child, a neonate or an infant, a young infant, in such cases, no, we need to give IV antibiotics. Otherwise, on OPD basis, most of my patients are treated with oral antibiotic. And even if I give
Okay.
a parenteral antibiotic, I would not do it for a very long time. So maybe 2, 3 days. If the response is good, we can again switch over to the oral antibiotic.
Okay, Vikrant, how many days of treatment?
As Satish rightly pointed out, if the child's clinical condition is good, we can directly go ahead with oral antibiotics. If you're thinking of a lower urinary tract, yes, 3 to 7 days of antibiotic would be suffice. And if you're thinking of an upper urinary tract without any lobar nephrogenia, something like that, you can go ahead with 7 to 10 days of antibiotic. That would suffice without any
Okay,
complication.
Pankaj, lot many patients who have symptoms pertaining to UTI with some BBDs are invariably lower UTIs. You don't find any abnormalities in the kidneys. How many days of antibiotic treatment?
Again, the age of the child, because in children you cannot differentiate between a lower and upper urinary tract infection. If you are convinced it's an adolescent or an 8-year-old child where you know that, as you said, no fever, lower urinary tract, then you get 3 to 5 days. But if it is any suspicion that there is fever or the risk of migrating upwards, 7 to 10 days minimum.
Okay, let me come on to cystitis because that is invariably reported in ultrasounds KUB. So they say bladder probably thick walled, and at the same time I find that the bladder was empty; it was not full. So Pankaj, your comments on these ultrasound KUB reports: bladder wall thickened. No
It's complete.
irregularity, but bladder empty, or maybe less amount of urine there.
Yeah, so I think they are complete nonsense, to be absolutely polite. Because unless the bladder is completely full, well, bladder is like a balloon. So unless your wall is thin by the volume in the bladder, it cannot be commented as thick wall. So you need to know the bladder volume of the child. So age multiplied by 30 is the minimum volume that the bladder should contain for you to comment on the bladder thickness. So if the thickness of the bladder wall is more than 2 millimeter in that case, then it is supposed to be a thick walled bladder, and then you can think about other
Yeah,
things.
so I think on dot. So unless the bladder is full, please do not comment on bladder wall thickness or irregularities. Sometimes you have only ecogenic shadows, Pankaj. What do we do? Ecogenic shadows in bladder reported.
Okay, there are two different aspects. One is floating debris ecogenic bladder in the in the bladder, where you there's no other evidence of urine infection. The commonest reason is the child not drinking well. So you get mucus in the bladder which is floating around, and that's why you get that picture. Ecogenic kidneys is not equal to urine infection. It can be because of multiple other reasons. The commonest being interstitial nephritis because of the drugs that we use, and it can even be dysplastic kidneys, which we never ever focus upon. Our focus has always
So
been
I am referring to cases where kidneys are absolutely normal. No
no,
dysplasia, no
what
ecogenicity,
talk
nothing. It is only pertaining to a lower UTI, so called in older children, adolescents, or sometimes even in children, younger children with BBT.
no, so that's what I said. So the two parts, one is floating debris in the bladder or ecogenicities in the bladder, is just because it's usually a child who's not drinking well, and that's the reason for the constipation in the bowel bladder.
Yeah. So most of my this webinar, we are discussing the clinical practice points which are invariably faced by us, yeah, rather than going into microbiology treatment and guidelines, because that is available to us everyone to be read on a public domain or a journal, whatever you say. So these are points where we falter, and probably the children would be spared of unnecessary antibiotics, and will emerge as an antibiotic steward. Okay, Satish, follow up urine culture, yes or no?
No, sir, not usually required. If the child is showing good improvement clinically, then there is no need to repeat urine culture. We just finish the course of the antibiotic as we decide, and then if we plan to do further no studies, we go ahead with that. But there is no need to do repeat urine culture. Repeat urine
Okay.
culture is important.
Vikrant, the choice of antimicrobials, third generation cephalosporins, third or fourth generation oral cephalosporins, and co-amoxiclav. Any difference of opinion?
Yes, sir. If the child is sick, clinically sick, child's infant age group, yes, I will go ahead. Or the child is dehydrated, vomiting, some toxic syndrome, toxicity in the child, yes, I will go ahead with a third generation cephalosporin IV. So soon the child is stable after maybe around 48 hours, I will de-escalate the antibiotics to oral. But if the child is stable clinically, but only with the symptoms, yes, I will go ahead directly with that of oral amoxiclav. That would be a choice of antibiotic. Or
What about
maybe,
cefixime orally?
yes, sir, it is a good choice, sir. So amoxiclav, cefixime, depending on the antibiogram of the hospitals or the locality. So I would rather prefer amoxiclav over cefixime because we have got lot many more cases of cefixime
Let's
registered.
let's let's forget about the culture. Pankaj, cefixime is a very preferred drug by many of the practitioners. Your take, but it doesn't figure into the list.
No, it is a very good drug. In fact, ISBN's guidelines mention cefixime.
Yes.
Yeah.
If I remember, it was third generation cephalosporin, which to my mind is called cefotaxime or ceftriaxone and
In the
coamon.
oral in the oral antibiotics,
The
they
oral, yes.
Okay. So now a question for you, Pankaj, again. There is a clinical improvement with whatever antibiotics we started, whether co-amoxiclav or cefixime. The child seems to be clinically improving. That means the symptoms of fever improving or urinary symptoms in an older child improving. But when the culture comes, it is an ESBL, resistant to ceftriaxone, cefixime. What do I do?
continue antibiotics, finish the course. The culture
This
is based on MICs of blood. whereas the antibiotics achieve a far greater concentration in the urine, and that is why the child is responding. So don't change if the child has responded.
Okay, so if the patient is clinically improving, while you do regard the culture which you have, which is positive, but however, the antibiogram which is there, and this is probably we are seeing in 60 to 80% of the urine cultures done in community which are reported as ESBL. Satish, do you find these situations?
Yes, sir, very commonly, very commonly. But as Dr. Pankaj also said that there is a lot of discrepancy between in vivo and in vitro sensitivity. If the child is clinically doing well, we should not go by the antibiogram.
Okay. So this is just to show you Cochrane review where it agrees that whatever we say amoxiclav or the third generation cephalosporin is a reasonable choice, which is done on a systematic analysis. Now a very common clinical scenario. The child is febrile, urinary symptoms are plus minus because the mother is not sure. And as usual, every family physician or a pediatrician somehow for reasons unknown to me that CBC, CRP and urine is sent. Now CBC is 11,000, poly is 56%, CRP is just 16, positivity 10 milligram per liter. Urine routine leukocyturia 7 to 10%. Diagnosed UTI, antibiotic started. Urine culture not done. What do I do?
Sir, as a clinician, I would actually put a stop to everything. Observe the child. If child is not very sick, if it can be managed on OPD basis, I would go ahead and do the urine culture and observe her. And we will also try to find out some alternative diagnosis. Based on these reports, I do not label these as a UTI. And if child is not sick,
Vikrant,
I would like to
do you
observe.
face such scenarios?
Yes, sir.
Yes,
It is a
sir.
very common scenario, sir. It is a very common scenario, and we do come across. So, leukocyturia is present, as Pankaj sir rightly told in the beginning, that in a clinical symptomatology of urinary symptoms, along with that leukocyturia, yes, the clinical diagnosis is UTI. But one thing wrong has happened is that we have not sent a urine culture. But someone has started a matlab, antibiotics. So let's treat that for at least for maybe if you're thinking of a lower UTI, 3 to 5 days or 7 days. If you're thinking of an upper UTI, maybe around 7 to 10 days. So complete the antibiotic course in my point of view, along with the ultrasound KUB.
Sir, you're not
Pankaj, do
mentioning the
you
age of
agree?
the child. Age of the child, you're not
It's
mentioning.
very true. Depending on the
Okay. So I think a good question. If below 2 years, probably I would be wary of stopping antibiotics. More than 2 years, I would assess. Pankaj, any difference of opinion?
Yeah, I think the first question is at what time did the child come to you? After how many days of antibiotics?
2 days. Two
2
days
days
of
of
antibiotics.
antibiotics. And as they rightly asked, what is the age of the child? If the child is younger, and if you have already finished 48 hours, how is the child? Has the fever gone away or is the fever still there?
Fever persisting.
Fever persisting. So
Yes.
if your fever is persisting, the antibiotic is not working 48 hours. So you send your urine tests again to find out what is happening. But if
Culture.
no, I know, but then your antibiotic is not working, you can stop it. If the child is getting better, see, whichever way you do it, you're going to be wrong. Whichever way you do it, you're going to be right. All that I would say is at the end of whatever you do not label it as a urine infection. So consider it as a probable UTI. Don't go down the path of investigating the full routine, but do an ultrasound in this
Okay,
case.
so I agree. One, if the fever has not responded with 42 to 72 hours of a antibiotic which is started, let's say coamoxiclav, which is a favorite, and cefixime is another second favorite. If it was definitely a UTI, the patient should have responded by now. If the fever persists, I have two possibilities. Either it is genuinely UTI for some other organism or E. coli which is resistant, or I look for an alternative diagnosis. Do you agree?
Yes, completely.
yes, sir.
Okay. So this is a list of antibiotics. I will not go into details. You have the doses. This is a textbook kind of a table. So Vikrant, complications of UTI.
As we are always as a pediatrician, we are really afraid of the complications of UTI. So two things are very important. Yes, one thing is that the child may land up in end-stage renal disease or renal scarring or late-stage hypertension. or other complications like in a young newborn or an infant, yes, it can move into generalized septicemia, or if it is localized, can present as a renal abscess. So these are two predominant things I would look for as a complications.
So Pankaj, what about chronic issues with UTI?
It's a very interesting question that you asked. Can I ask you back a question?
Yeah, please go ahead.
Okay. What is the prevalence of end-stage kidney disease today?
I would not be able to give you a percentage, but it is not, I would not say it is very common. At the same time, I would not say it is very rare. But
No.
yes, you do find certain patients who come out with a bad KFT and they are misdiagnosis and urogenital abnormalities were not diagnosed because it was never suspected and an ultrasound done.
No, Dr. Chitkara, my question was different.
Yeah.
I'm asking you a very simple, and this is all there. Everybody can read about this. So if I look at United Kingdom, if you look at the world, the incidence of end-stage kidney disease in children is given per million children. And that has gone up to something like 80. So you can vary from 50 to 100 per million children. 20 years ago, the incidence was about 15 to 20. Now, in the last 30 years, we have been extremely aggressive about treating urinary tract infections. We keep on talking about missed urine infections, whatever. Let's say Western countries do not miss urine infections. And what has happened to the end-stage kidney disease numbers? They have gone up. They have not reduced at all. So we are focusing on the wrong aspect. I think, I'm very sorry to say, I think this is something that we need to understand, that it is underlying kidneys which are a problem. It's not the UTI per se. In fact, there are studies which show that if you're born with perfectly normal kidneys, you will never damage them, even if you get UTIs. The problem is that they are born with abnormal kidneys and we are not picking them up.
So you are raising a very pertinent point. So I ask you, any Indian data on CKD in children less than 12 years or less than 15 years or less than 5 years?
We don't have numbers. We are just collecting them. We have just started.
We don't have documentation. And
Yes.
the next question. If I say CKD in children, one of child, and I do an ultrasound or whatever imaging investigations I do, is dysplasia more common than the urogenital obstructive diseases, uro-obstructive diseases?
Sorry, I didn't get a question.
Question is, if I see a patient of CKD, or invariably in totality patients of CKD, chronic kidney disease in children, is dysplasia more common than a scarring because of a UTI, missed UTI?
No, dysplasia is there right from birth. The UTI does not play a part at all. It may worsen or hasten the functioning decline. But there are so many patients that I have who are on dialysis at present and they have chronic kidney disease secondary to renal dysplasia. We are just not picking them up. And all the adults between 15 to 30 who present needing dialysis, they are the ones we have missed when they were children. So we have just.
So I'll frame this question in another way. Those children on dialysis or a chronic kidney or decompensated kidneys, are dysplasias more common, or missed UTIs or untreated or poorly treated UTIs more common as a cause of these?
Dysplasia.
Huh? Dysplasia.
Yes. All over the world. It's not just in India. Because if you look at end-stage renal data disease all over the world, they used to call it as reflux nephropathy 25 years ago. Today, that term has virtually gone away. It has all shifted to dysplasia.
So if it is dysplasia, which is more of a congenital outcome, are we blaming unnecessarily UTI for chronic kidney diseases in children?
If you get repeated UTIs on the setting of dysplastic kidneys, you're going to damage them more.
Okay, so it is an add-on insult to an underlying dysplastic kidneys.
But
is that a right statement to be made?
Yes, but even if you don't get UTIs, these children will end up with kidney damage.
Okay.
So that is what we need to pick up.
Okay, so we
Sir,
are worried
I
about
have a
the
question,
only.
Chitkara sir.
Yes, sir.
We are talking about end-stage renal disease in kids, I mean children. Up to what age are we talking about? I mean, does UTI or recurrent UTI or a normal kidney can cause long-term damage in a way that there is an adult onset of this CKD, etc. My question
Okay.
to
I Satish asked a general question in a pediatrics age group, which you may take till 12, 15, or 18. And I wanted this answer from Pankaj that all those children who are on dialysis below, let's say, 18 years of age, was dysplasia more common than the missed UTI, or it was a combined UTI versus dysplasia, to which he informed that UTIs, missed UTIs in a dysplastic kidney are probably the most important culprit. Is that a right statement,
No, I
Pankaj?
think the answer is dysplasia is the commonest. They don't get
Dysplasia.
urine infections at all as they grow older, but their kidney function. Just to give you an example, last week I got two calls from adult nephrologists because in Navi Mumbai area now everybody knows about this dysplasia. Unfortunately, none of the nuclear medicine departments report this. Everybody talks about scarring. They do not understand dysplasia at all. But I'll just tell you the two examples. One was a 44-year-old female who had one UTI at 15 years of age, and today her creatinine is 3.5. She never
But
had
tell
even
me one,
one
tell me
question.
one thing. In a scintigraphy, whether it is a dysplasia or whether it is a scarring because of a UTI, they would appear as a filling defects. So how do I differentiate?
So, one, the distinction has to be made by you, not the nuclear medicine guy. That's the first thing, because your clinical scenario will dictate what it is. Secondly, a dysplastic kidney has a diffusely reduced uptake. It's like if I take a picture of a kidney and take a paintbrush with black paint and paint it all over, that is the appearance of a normal kidney. In a dysplastic kidney, it will be like sketch pen. You have filled it up with sketch pen, dotting it. So a diffuse uptake is more likely to be dysplasia. So a scar typically definition is a wedge-shaped defect from the periphery to the hilum. And that is very often not seen. It's more diffuse blob of tissue that is seen, which is reported as scarring.
So Pankaj sir, one thing to add.
Yeah.
You rightly pointed out, sir. Yes, dysplasia is a more common cause, but anyways, dysplasia is going to have some problem later on. But we are discussing about the naive kidneys, which are right away normal kidneys. So the question was very simple: that is the febrile UTIs are going to increase the risk of scarring and end-stage renal disease? Because in a dysplastic kidney, it's very difficult to prevent all these end-stage renal disease. But in a healthy kidney, so this risk of UTI, this UTI does increase the risk of end-stage renal disease or not? Because as a general pediatrician, we would rather be more interested for
Correct.
UTIs.
So Vikrant, I think
why
Vikrant, it has to be taken in the right perspective. Number one, as I said, UTI is an opportunity or a sentinel event to bring out urogenital abnormalities, or I would say urinary abnormalities, and dysplasia is one. And UTI is an added insult to a dysplastic kidneys. So if we may remember this, then probably think of these patients. And dysplastic kidneys would also have a recurrent UTI, which we are going to discuss in our future slide. So this is a statement in a right perspective, and I hope my panelists agree with me. Just to update you that E. coli, which is a ESBL, is increasing by the day and is increasingly being reported. So don't be surprised when you get urine culture reports of ESBL. However, as rightly said, if responding to your conventional treatment, then you just continue with the treatment rather than change drugs. Satish,
Yes.
are you overloaded with patients who are on these oral carbapenems? Because it has been introduced, and when we say E. coli is becoming ESBL or other Enterobacteriaceae is we say ESBL.
Sir, fortunately, I do not get such patients who have been given oral carbapenems. So I do not have much experience about how my patients responded to that or not, nor do I have any opportunity to use
Okay,
oral
so let's move on to Pankaj. Pankaj, use of the Are these kind of unnecessarily promoted drugs? Do we really require? Do they have any indication in children? Pankaj.
No. The answer is no. I've never used it, and I don't think they're indicated.
Okay. So to update my panelists, this ferropenem, which is available in India, has never been a licensed drug anywhere in the world except in India. The actual oral carbapenems which are licensed are tebipenem and sulopenem, starting in Japan and some US and European countries. But this ferropenem is out of the blue in India. We have no kind of an experience with this, but it is promoted as a panacea for everything, right from upper respiratory to a UTI. My pediatricians colleague in discussions do feel that sometimes ESBLs not responding to conventional treatment, probably this may be an indication. But I till date, I have never used it, and I have never entertained a medical representative coming to me with these oral carbapenems because I feel meropenem's resistance, cross resistance would be promoted by this, and I should not be a contributor to that meropenem resistance. Do my panelists agree?
Yes.
Okay. So Pankaj, you agree?
Yes. Completely.
Okay. So now the mother of all questions, evaluation after the first episode of UTI. So we have Satish, your take on these imaging modalities.
Yes, yes. In all my patients who have UTI, I always go for USG, once the child is settled. But for MCUG, now the guidelines have changed. I mean, we are more aggressive earlier, as you started your presentation with that all children were subjected to all these modalities. But now we do not subject them. Only if there is a recurrent UTI or if there is a USG abnormality, then only we go for VCUG now. So I do not routinely go for VCUG anymore. I do go for USG and look at if there are any abnormalities on the USG. If there are not any, then I will just have a good surveillance of the child. No, I would warn the parents that whenever there is a fever, and especially without any focus, get the urine routine at least examination done on their own, so we do not miss out on a recurrent UTI. And if they end up with recurrent UTI, yes, I will go for VCUG.
So these were the listed imaging modalities. We'll come to individual, and when we this is an algorithm ISPN 2023, as I said, published in this, and various international guidelines. Pankaj, why is there a difference in international guidelines vis-a-vis an ISPN guideline?
No, so if you need to understand the trend of how these guidelines came into being. So in 1991 was the first time when people sat down, the working group of the Royal College of Physicians, to decide that you need to have a uniform investigative approach to children with UTI. Because before that, people used to do anything. Some people did IVP, some people did MCU, some people did it. So when that working group came into being, the idea was that we need to have a uniform guidelines as to which investigation to do. And therefore, they overloaded it because you had so many people, they all wanted these investigations done. So it was not the bare minimum, it was the maximum that could be done. And therefore, you had an MCUG, a DMSA, and an ultrasound. Now, as time passed, we have now realized, as I just said a little while ago, CKD numbers don't change. In fact, if you look at CKD data, they have very clearly said that the expected reduction of numbers by treating reflux has not happened at all. So we are barking up the wrong tree. And that is the reason why we are now focusing on the fact that we probably need to reduce the investigative load and use it only as a directed approach to where we think there may be abnormalities rather than in everyone. And just I don't know whether there is a talk. I think you have already put it there.
So yeah, so I have shown you an algorithm which is the current algorithm 2023.
Yeah.
So you have what emerges is ultrasound in all any febrile UTI, and you have a definitive indications for an MCU.
Yes.
And I would probably ask Vikrant, when do you order an MCU or what we call as a VCUG? Remember, avoiding cystourethrogram is most important. At the same time, because you pick up other issues, especially in a young infant.
As sir, you rightly told in the early beginning of your slides that we are cutting down and we are closing and becoming narrowing to decrease the risk of these radiations and all. So routinely we'll go ahead with the ultrasound KUB, and if you find any abnormalities in the ultrasound, then we'll go ahead with the NCUG or non-E. coli UTIs, or if there is a recurrent febrile UTIs. So these are the indications we need to go ahead with the MCUG, and which can jolly well can detect 90% of the grades of VUR. And if you find any abnormalities, then you can go ahead with the late DMSA.
Okay. So therefore, like these indications are specific, and I am not going into the details, except that these algorithms will keep changing. But however, the consensus is that children below 2 years or 1 year, depending upon various guidelines. Pankaj, 1 year or 2 year?
No, the older guideline said 1 year. But
Yes.
now we are not doing it even for children less than 1 year. We are doing it only if the ultrasound is abnormal.
Okay. So perfect. So what? So it is not even 1 year now.
Yes, now we are saying that MCU, as I think he rightly pointed out, we do it in children where the ultrasound is abnormal.
Right.
Or if there are other things
Okay.
that come into play, like you
So
suspect.
only abnormal ultrasound is an indication for MCUG, and you are more permissive when it comes to children below 1 year or below 2 years, and especially female child. Is that a right statement?
Yes.
Yes.
Consensus? Okay. So
Yes.
now we are almost overshooting the time. So I'll 3, 4 more slides left, but there are certain points which are to be hammered back home. So recurrent UTI. Satish, what is recurrent UTI?
Any episode more than once is a recurrent.
Okay. So, but if you see as a general pediatrician, anything recurrence, whether it is febrile convulsion, diarrhea, respiratory infections, you say more than 2 in 6 months or more than 3 in 1 year. So, what is so special about UTI that even more than one
As
is
you
kind of
very
recurrent?
said no earlier also that this is one disease which is looks so simple, but it has so many complications and we miss a lot of things. No, that is why with UTI it's an exception that recurrent means only more than one episode. Your antenna should be up and you should be investigating the child.
Okay, Pankaj, are you okay with this?
Not entirely. If you get one UTI at 1 year of age, the second one 12 years of age, is it recurrent UTI?
No, I said within a year. Within a year.
Because
within a
I
year.
think he said without any time. So I think it's
मुझे
not.
बचपन में निमोनिया हुआ 70 साल में निमोनिया हो गया थे that is
That's not recurrent. Yeah, I agree. I agree.
Okay. So Vikrant, this is BBD is in discussion, and why is it in discussion is because I said constipation is almost an epidemic for all most of the pediatricians. I do not know about West or East or South India, but North India, everyone seems to be constipated these days. और मेरा एक वो typical वैसे भी वो होता है Indians, unless they eat well and pass about 5 kilograms of shit in a day, no one is happy.
Very true, sir. Rightly told, sir. Yes, constipation, we are getting plenty of cases and not responding to the things. So very important is the dietary habits, because plenty of kids do come with only diet having biscuits and milk. So
Okay.
these are the routine staple diet.
So what is BBD? Bladder bowel dysfunction.
So bladder bowel dysfunctions means bladder symptoms like urgency, frequency, straining during maturations, all these symptoms, along with that of bowel dysfunctions, predominantly the constipations or the hard stools. So these need to be taken care, and more importantly, the adequate toilet training.
So what do I concentrate more on? Prevention of UTI or treat constipation?
So very importantly, first thing is what is the cause? The root cause is the bladder bowel dysfunction that is causing this UTI. So very importantly, we need to address these bladder bowel dysfunctions. by the behavioral therapists, by regularly cleaning the regular habit of toilet trainings, and more importantly ask them to urinate frequent intervals, and importantly ask them to have some proper dietary modifications. Along with that of toilet training, every day the child should sit in the commodes or the toilets wherever he is comfortable, morning and night, and should sit. Along with that, if required, some medications may be used to treat the constipations.
Okay, Pankaj, whenever we talk to any gastroenterologist or other who are treating constipation, and we as a pediatrician land with urinary symptoms in a constipated child, there is a word which is urotherapy, well established. But somehow I don't understand the components of this urotherapy. Now, especially adequate intervals between urination. Does that mean number one? And number two, you sit down, the mother or the father, the parent, they sit down during the day and keep on writing down how many times voided. What do you say about this?
I think there are two things that you need to realize. When we say bowel bladder disturbances, it doesn't necessarily mean, I think Dr. Kruti rightly said. So there are two different aspects to it. Those who are constipated tend to retain urine. So these are the retainers. So they void less frequently. So the number of voidings in a day should be at least 6 to 8. So they are voiding less than 4 times a day. So in these patients, you have to treat constipation. You have to make sure they're regularly voiding. On the other hand, you can have a separate issue where they have detrusor instability. And this detrusor instability actually causes them to void 50 times a day. They have urgency, they have daytime wetting. So in this case, you're telling them that the child has to void 8 times a day has no meaning whatsoever. The child is already voiding 40, 50 times a day. What more are you going to do? In these cases, where while you're treating constipation, you actually will need to use anticholinergic medications to relax the bladder to allow them the facility to void at appropriate intervals. So a voiding diary is important to know how many times the child is voiding. That will give you an indication of what you need to do.
So are you recommending all these troponins for this anticholinergics?
If they have detrusor instability, yes, they will never get better without that.
Okay.
Unless you get rid of the causative factors. So one is constipation. The second commonest thing you find is stimulant drinks like tea, coffee, and fizzy drinks. Because
So
the
what is
parents
an optimal posture for voiding in children?
voiding.
Optimal posture during voiding.
Right. So there are two things that you need to remember. One is in girls, when they sit on the toilet, you should make sure that the vagina is facing downwards. Because otherwise, when they stand up, the urine pools and they will start wetting the underwear. In boys, you need to make sure that they shake the penis after they have voided so that the urethra empties. Now, these are very basic things that need to be told. Apart from that, the regular voiding that we say, and sometimes in children who have constipation and are retainers, you need to tell them to practice double voiding. So they need to go to the toilet, pass urine, count from 1 to 20, or sing a fairy tale or or a poem and pass urine again.
So is squatting better than using a Western commode?
Sorry, is Indian toilet? Yes.
Indian squatting vis-a-vis a Western commode.
Yes, it's certainly better for constipation.
What? Squatting?
Squatting, yeah.
Okay. So yes. So these are the points. So VUR is most talked about, and again, as I said, when you do an ultrasound and you find there is some evidence of VUR in the form of calicial dilatation or a dilated ureter, and that depends on the kind of competence of the doer. So we many a times we ask for a USG KUB from a person whom we really believe to be a good ultrasonologist, because there is a doer bias in all this, and the prevalence is quite common, especially in those patients who come with UTI. So since this is a kind of a stand-up, these are the ones who will go into renal scarring, and probably higher degree of VUR is more important for us what I need to discuss in a clinical scenario is, Satish, antenatal hydronephrosis. Some children come that antenatally diagnosed as hydronephrosis. What do we do about them?
We monitor them, the AP diameter of pelvis. We don't put them on a antibiotic prophylaxis. It's just enough to keep monitoring them and look for incidence of urinary tract infection.
So, Pankaj, what do you call really a progressive hydronephrosis? He said the renal diameter. And I think renal diameter or the renal dimensions vary with age. Is there a cutoff?
Anything less than 10 is normal. Anything more than 10 is abnormal from a pediatrician's
I
point of
agree.
view.
I was under the impression 9, but yes, 9, 10, it's okay.
Yeah.
So anything more than 9 at any age?
Yes. It's the progression that matters. So if you have got an AP diameter of 15, which is becoming 12 and 11, it's a good progression. It is improving. Whereas if you've got a 11, which is becoming 12, 15, then you will need a nuclear medicine scan to determine whether it is affecting the kidney function.
Okay,
Associated things are calcium dilatation and parenchymal thinning.
So progressive hydronephrosis and that renal pelvis size tells us whether we do it MCU or a DTPA scanning. Role of DTPA scanning in these children.
Yeah, so if you have got isolated hydronephrosis without hydroureter, the choice of investigation in case the AP diameter is progressively increasing is an EC scan or a DTPA scan. So it is basically a dynamic scan. In very simple terms, you inject a color through the vein and you find the color coming down through the kidneys in the ureters and the bladder. So if you have obstruction, you will pick it up. But more importantly, you will find out what the kidney function is. So if the dilatation is affecting the kidney function, then some intervention will need to be done. If the kidney function is okay and the drainage is slow but present, then we usually just wait and watch.
So progressive hydronephrosis, but when a DTPA is done, it shows non-obstructive PUJ obstruction. It relaxes. What do I do with them?
You monitor them. So if you have done it, let's say at 15 millimeters of AP diameter, and your DTPA now shows that it's draining fairly adequately and the function is maintained, you repeat the sonography in 6 months. So the chances of increasing of the diameter and intervention being required are maximum in the first 2 to 5 years. So if the dilatation is decreasing,
yeah, that brings me to the question: how often a follow up with an ultrasound?
6 months. So if you have done an EC scan, then you repeat an ultrasound in 6 months, as long as
I have a patient, like many patients, antenatal hydronephrosis. We do it at immediately post birth.
Correct.
We assess them, and then the next ultrasound scan we do at about 1 month, and then depending upon what we get, if we get a progressive, then we go for a DTPA. If we find a non-obstructive kind of a PUJ, we tell them to come after 3 to 6 months. Is that a right follow-up or no?
If you have done a DTPA and it doesn't show obstruction and the kidney function is okay, repeat it in 6 months. Nothing is going to change.
If it shows obstruction, then?
If it shows no. So what you need to understand is as the child grows older, the PU junction also gets bigger. So if the function is affected, unless the kidney function is affected, you don't necessarily go in for surgery. So if you see evidence of obstruction on the DTPA, you still just repeat the scan after 1 or 2 months. And if the dilatation is decreasing, then you continue monitoring the child.
Any objective figures for a differential function, like I get 48 versus 52%?
That's normal.
Or I get 30% versus 70%?
Yes, so any difference of 10 between the two is normal. Anything more than 10, you need to be careful. Anything less than 40 on one side needs surgery.
Okay, that's what I wanted from you. So it is a lesson for all my general pediatric colleagues. The difference of more than 10 or less than 40 in a single kidney is worrisome, and probably we need to act. Is that right?
Yes.
Okay, Satish, chemoprophylaxis for these antenatal hydronephrosis. I find it progressive.
If it is progressive, then yes. it is not progressing, as you already written, 90% would resolve on their own. And a good surveillance is necessary, and antibiotic prophylaxis only if there is a progressive hydronephrosis.
Vikrant.
Yes, sir, rightly told, sir. If it is a progressive with a VUR maybe of grade 3, 4 or more than that, so we need an antibiotic prophylaxis. So if child's age is less than 3 months, cephalexin would be a preferred choice. If child's more than 3 months of age group, then nitrofurantoin, or we can
No,
go
no,
ahead with
I'm not coming to drugs.
Okay,
Chemoprophylaxis, yes or no?
Yes, sir.
Pankaj.
Isolated hydronephrosis, even if it is progressive, does not need chemoprophylaxis unless you have shown that it is reflux which is present.
VUR
And
grade 3 or
Reflux.
more.
And there
So
also
the guidelines
fine.
mention if it is progressive, either pending evaluation or progressive, which is non-obstructive, probably you should not be using chemoprophylaxis unless they have a UTI. Is it okay?
If it's a grade 3 or more?
So no, I think he's talking about PUJ obstruction. PUJ obstruction does not need prophylaxis.
Okay.
Reflux,
So, yeah.
reflux, you can give
Reflux.
prophylaxis.
Yes.
So it's 6 months to 1 year.
Progressive hydronephrosis antenatal. I have done a USG, it shows progression. I have done a DTPA, it shows 48%, 52%. Is that a candidate for an MCU?
Only hydronephrosis, no hydroureter.
Yeah, at the moment, ultrasonology says hydronephrosis, not commented on ureters or ureters sometimes not visualized.
I wouldn't do an MCU.
No. So when do you do an MCU
If
in
you
a
have
patient of progressive antenatal hydronephrosis?
if you have a dilated ureter, if
Okay.
you have hydroureter present, if you have a distended bladder where you suspect a bladder outlet obstruction, MCU becomes urgent.
Okay, so that makes it is imperative that surgical intervention required or not depends on what kind of an obstruction or hydroureter you are expecting. So you need go for re-implantation and others. Okay, so I leave it to that. DMSA in these children of antenatal hydronephrosis progressive with no intervention done. DMSA required or no, Pankaj?
No, if you have done a DTPA or an EC scan, it's as good as a DMSA scan. So
Okay,
isolated hydronephrosis where you have done an EC scan, you don't need a DMSA. If you have
okay, if a progressive antenatal hydronephrosis gets an episode of UTI, confirmed UTI, do I need to do a DMS after 3, 4, 5 months?
Yes, depending on, again, it all will depend on the individual patient. But what I was trying to say is if you have got high grade reflux, you do want to do a DMSA irrespective of whether the child has had a UTI or no, because that's where the risk of dysplasia is the maximum.
Okay, so Vikrant, you were coming on to drugs for prophylaxis. Are there specific indications for a chemoprophylaxis?
Yes, sir. Rightly told by Pankaj sir that if the child is having a high grade reflux, that means 3 or more, then the child may need an antibiotic prophylaxis. As rightly told by me earlier, if less than 3 months, we can go ahead with that of cephalexins. More than 3 months, nitrofurantoin, or we can go ahead with trimethoprim with sulfamethoxazole.
Nitrofurantoin in an infant is very unpleasant. At the same time, it is not available in a kind of a syrup. What do I do?
It's available in nitrofurantoin tablet that I don't want to utter that name.
That doesn't dissolve. It is a film coated tablet. It doesn't dissolve.
So true. So we can go ahead with cotrimoxazole with trimethoprim 1 to 2 milligram per kg. That would suffice, sir.
I am worried about cotrimoxazole in North India, where G6PD deficiency is anything between 8 to 20%. Satish.
Sir, in that case, I would test for G6PD deficiency. And if that is also not possible, then we can go with cephalexin also. I mean, that's the last resort. Not a preferred antibiotic for long-term prophylaxis in.
Pankaj, your opinion.
Yeah, so unfortunately in India, we do not get trimethoprim as a single agent. What you said is absolutely right. Because of the sulfa component, we have a problem. Secondly, cotrimoxazole is very often not available. So it comes into the market or it goes away. So cephalexin though it is not the ideal preventive agent that we want, you can use it because it's freely available.
Okay, duration of prophylaxis.
Right. The duration, previously they used to talk about years of prophylaxis, that has been completely given up. So we talk of 1 year if it is an infant, 6 months if it is an older child. I know you have put 2 years there.
Okay, so message for my audience is prophylaxis to prevent only recurrent UTI, but ultimate outcome as far as caring is concerned, there is no role at all. So we do not have final answers still on prophylaxis, except that we have reduced the duration from 5 years to 2 years now. And there are specific indications where you use prophylaxis, higher grades of reflux, 3 to 5 reflux degrees, BBDs, where you are managing the constipation. At the same time, you are also preventing those who get into UTI young age and not circumcised male. So circumcision sometimes is a taboo in Hindu population, so I would not fall for that. So this is a prophylaxis basically to prevent renal scarring, which is really does not as per the Cochrane analysis. And there are issues with the long-term antibiotic administration. If you give it, even if you give it on a kind of a subtherapeutic dose and once a daily dose, and so even surgery and other whatever interventions you do really are unable to prevent scarring, except that you treat obstruction as well as you prevent recurrent UTIs. This is a standard table adapted from the 2023 guidelines. I'll not go into the message. So finally, I'll end that UTI is a serious bacterial infection, simple yet complex if it is missed and because of the complications which ensue. Urine collection is the most important aspect we must take into account. We must treat early, depending upon the sickness of the child. Oral therapy is in vogue rather than parenteral, except for very young children who are kind of a sepsis-like profile or not taking orally. These indications were mentioned by Satish. And invariably, these children should be evaluated with an ultrasound for an underlying obstructive diseases, VUR and DBD. And you have very limited indications for antibiotic prophylaxis. And those who do not opt for surgery, whether it is reimplantation or whether it is an endoscopic bulking agent. So these are individual choices. So always make individual patient choices depending upon the problems as well as how you assess them. So finally, thank you all my friends. I never thought UTI simple diagnosis would last almost 1.25 hours in discussion. I thought it was a very simple kind of a discussion. So thank you all. If there are any questions, we can take Dr. Chetan and Dr. Manish. I'm stop sharing. Chetan, Manish.
Yes, sir. Yes, sir. You still sharing.
Okay, I think most of our organizing people have gone off to sleep.
You've not stopped staring yet.
Yes, screen is still seen.
Okay,
If you are
hold
not
on.
able to
Stop sharing.
Yeah. Thank you
Yes.
so much, sir. Yeah, it was very interesting discussion because it was not that typical discussion what we expect or anybody will expect. But this was definitely a fruitful discussion, of course. Manish, there are 20 questions if you can take it.
Yes, yes.
And I would like to ask Dr. Pramod Kulkarni, he has put 2 or 3 questions. If you can ask directly, by that time, Manish can look at the question in YouTube. Dr. Pramod?
My question to Pankaj is, Pankaj, diagnosing UTI in kids who are already diagnosed to have CACUT, do the diagnostic criteria differ?
No, and not only do they not differ, I think it remains the same whether you have kakut or no, unless the child has symptoms. Don't do a urine sample, because very often you find people saying do a urine sample every 15 days because the child has had whatever kakut condition. No, That doesn't hold true. Surveillance samples are out of question, and unless the child has symptoms, urine samples are not to be done.
Then same one question about the UK guidelines which use dipstick as a screening intermediate between culture to save on cost. So is it a right practice to do?
I think it's as good as doing a urine routine. If you have done a urine routine and it shows leukocyturia, you send a urine culture off. So your dipstick is detecting leukocytes and nitrates. So either of the two is fine. There, what happens is that the health visitor or the practitioner nurse does it in the clinic itself. Now we don't have that facility here. So unless you get up from your chair and actually go and do it yourself, that becomes a difficult aspect.
This ISPN guideline, no, it equates microscopy with dipstick.
Yes.
Okay.
I think most of the questions are from sir only.
Sir, there is a question. Suppose if you have, say, 6 to 7 cells in urine routine micro, right? And or maybe say they write around 4 to 6 per cells or 5 to 6 per cells. This is standard practice. And the culture report shows more than 1 lakh colony count. That's the E. coli. And it is fitting into the clinical scenario. Do we treat it as UTI?
If it is an older child, it's very, very unlikely to be a urine infection. It's contamination. Go back and recheck how the urine was collected.
And usually it is less than 2 years.
Symptomatic, you said
if it is a child, but if it is an older child, if it is a full symptoms like, for example, dysuria and whatever, go back and recheck whether the child has UTI mimic 1 or 2, which I think Chetan I talked about when I came to Mount Abu. So you will have vulval redness or you might have detrusor instability, and which is why these children come up. But if it is a child who's less than 3 months of age with these kind of scenarios and the child has fever, you'll have to consider it as a UTI.
Hey, suppose this is usually a 2 years of age where we don't get very typical symptoms of UTI and where we suspect maybe fever or vomiting and we suppose nothing we are finding, we just go for urine routine micron culture. In that sort of situation, when we clinically feel that there is no reason for fever and it's a young child, so should we treat or we should wait?
No. So what have you done? You've got your urine routine back. What have you done? Have you started antibiotics or not?
No. We sent the urine routine micron culture.
Okay.
First, they came the urine routine micro showing 5 to 6 or 6 to 8 cells.
But the culture came 48 hours later. So what did you do in the 48 hours in between?
No, but because 5 to 6 cells, we didn't start any treatment.
Correct.
Okay.
By
Next
the time
day,
the culture comes back, if the child has become better, don't treat it.
no, but which child is having fever.
Sorry, if the fever continues, treat it as a urine infection.
Okay. So in this case, you don't get the pyuria with this thing because this is routine.
I will still be very skeptical of diagnosing it as a urine infection. But if the child's fever continues and you've got a culture positive, you'll have to treat it as a UTI.
Okay.
So Pankaj, just an interjection here. Older child with urinary symptoms, no leukocyturia, but culture positive.
No, so that's what I said.
Treat as UTI or no UTI?
No, urinary symptoms may be because of vulval redness or maybe detrusor instability. You need to go back and check. Because I have found patients who have been treated for 1 year, antibiotics continuously because the child had detrusor instability, frequency, urgency. That was missed.
But Pankaj, local inflammations, local vulvitis will really not lead to urgency, will not lead to dysuria. They may have a local burning sensation, but they don't have fever and dysuria in vulvitis and all those local issues.
No, what I'm trying to tell you is dysuria, urgency, frequency. Those are the symptoms that are present. It can be detrusor instability, because that's typical of detrusor instability, and that's far more common than urine infection.
But with fever, I am talking of a febrile child.
Correct. Again, fever with that, you will expect to find pyuria in the urine. If you don't get pyuria, be very careful of diagnosing a urine infection.
So can we conclude, Dr. Pankaj, that there has to be leukocyturia to make it a diagnosis of urine culture positive?
Local inflammation has to be present. How can you get a urine infection without local inflammation? If it is a younger child, immunocompromised child, yes. Older child, you have to have pyuria.
Okay. So I see a question in chat box. Someone has said ferropenum is not a carbapenem. These are all carbapenem, but this is an oral carbapenem. carbapenems invariably are required IV. They cannot be given orally. So these are variations which are oral carbapenems. Carbapenem is a big group which contains all those Miro, Imi, Tabilo, Sulopenem. So it is a carbapenem, but an oral carbapenem, which is, as I said, not licensed across the world except in India. So,
Pankaj, one question for you.
Yeah.
In many of the infections like diarrheal illnesses, pneumonias, unspecified fever, uh, urine shows leukocytes. Is it a how many times genuinely it is likely to be a UTI?
No, you shouldn't be sending a urine sample in these cases.
So
Fever
no
without focus.
risk factor for UTI. So diarrheal illnesses also do not become a risk factor for UTI.
No, but if you have diarrhea, where you know that the child has got diarrhea which is present, which is causing the fever, why would we send a urine sample?
No, but there is a young child who can have UTI with diarrhea because of parenteral diarrhea. That also is one of the manifestation of UTI in very young kid, infancy. I mean, that is what the
That's all theory
guidelines.
stuff that is written. नहीं होता है. So unless, that's why I said fever without focus or urinary symptoms have to be your criteria. If you have a focus, so your respiratory infection, if you've got a child with pneumonia, you send a urine test, it will show pyuria. That is not a urine infection. You may get a culture positive also, it's not a urine infection. So it is always fever without focus or a child with urinary symptoms.
there is a very relevant question in the chat box on DMSA. Why interval DMSA? Why not in acute infection? I think that needs to be answered, Pankaj.
Yes. So if you do a DMSA in an acute stage in a child who's got pyelonephritis, the acute changes will be seen on the DMSA, which may completely resolve in 6 to 8 months' time. We are not interested in diagnosing pyelonephritis on DMSA. We are interested in knowing whether there are permanent changes in the kidneys which need a long-term follow-up. And that is why we say a DMSA to be done 6 to 8 months after the urine.
Okay, so that's because acute stage DMSA would be as good as showing a scarring. So that is why it is preferred to do it, because scarring would invariably diagnose, like guidelines mention anything 3 to 6 months or maybe 4 to 6 months.
4 to 6 months.
Yeah. So, Pankaj, is there a need to repeat DMSA in a child who has had a DMSA evidence of a scarring post a UTI? Do you think a follow-up DMSA is required?
No, so if you're talking of an acute DMSA which was abnormal,
No,
then
I'm
yes,
talking of an interval DMSA
correct.
showed scarring. Does that really require a redo 3, 4, 5 years later?
No. Please do not repeat DMSA scans. The interpretation of repeat DMSAs is complete nonsense. And I will put up multiple pictures to show you what has been done. So, for example, if I give you an idea today that a child has a DMSA where one kidney shows 35% function, the other shows 65% function, what do you think the DMSA will be 8 years later?
But what if VUR, high grade VUR persists, is not getting better,
But
and
that's
the
what
child does have 2 to 3 episodes of febrile UTI in between?
No, but that's what I'm coming to. So if you follow the natural progression of a kidney which has a reduced function, as the child grows older, the function will drop. So from 35, it's going to become 25 in 8 to 10 years time. So a repeat DMSA at that time is going to show a function of 25 and 75. This is not secondary to urine infection. This is a child who's not had urine infections at all. Even then it will drop. Now, if you want to add urine infections and say that this has dropped because of that, it is impossible to do. So I would.
Okay. Chetan, any more questions? Hello?
Chetan has left. Chitkara.
Yeah, no
Chetan has left.
further
Chetan has
questions.
left.
So, Dr. Bala, your comments?
Yeah. First comment, brilliant. brilliant presentation, as expected, of course, with Pankaj shining brilliantly. It was fantastic. I have a few comments. I will not take much time. Number one, in the presentation, I saw immunodeficiency and UTI. I think pediatricians should remember UTI is never due to immunodeficiency. It's an anatomical problem and it's not an immunological problem. Don't blame immunodeficiency for any UTI. That's comment number one. Two, I don't know, I saw in the picture Supra Baby. How many of you in the audience do Supra Baby? I have not done Supra Baby for the last 20 years. It has been given up. I think it's very difficult to do. In fact, it's very interesting to see the BMJ paper on quick wee method. Very simple method. I have used it for a few cases in my OPD. You apply saline, cold saline on the suprapubic region for a few minutes. Invariably, you succeed in 5 minutes. It's called quick wee method, published method. Very useful. It can be done. Third comment I just wanted to add. There was a discussion on pus cells being low, discussion on nitrites being absent, discussion on leukocyte esterase being absent. Could it still be UTI? I'm afraid it could still be UTI. In fact, studies have shown organisms like Proteus, Pseudomonas, if they produce UTI, the inflammatory markers, starting from CRP to total count to leukocyte esterase to nitrite to pus cells, do not go up as much as it happens in E. coli. There is a reference for it. So just because it is 5 to 6, particularly if you grow an organism like Proteus or Pseudomonas, don't ignore, and particularly Proteus and Pseudomonas, always look for a renal stone if there is a UTI. That's my comment, the other comment. The next comment is, I don't know, for some reasons, we tend to prefer cefixime. I can tell you, I use cephalexin in a high dose, 75 milligram per kg. The reason why I use as first choice is because it is rarely used. There is hardly any resistance to cephalexin because it's not being used. Two, the bioavailability of cephalexin is much higher than cefixime. It is mentioned in the US guidelines that cephalexin can be as good as cefixime. The caution for cefixime is that you have to use a higher dosage of 15 milligram per kg for UTI, not the Shigella dosage of 8 milligram per kg. The next comment is, if you have had a child who has been treated with UTI with an antibiotic like amoxiclav or cefixime or ceftriaxone in the preceding 3 months, if the child has got a febrile UTI, I would not be starting with ceftriaxone. I would prefer to cover for ESBL as a distinct possibility. If the child is toxic, febrile, I would start on piperacillin tazobactam. Next comment, Chitkara, you said that paropinum is carbapenem. I'm afraid only tebipenem and the other suropinum are carbapenems. Your pharopinum, which I call it as unpharopinum because it's being marketed unfairly, right? It's a pinum antibiotic. It's not a carbapenem. It doesn't come under carbapenem. It's a derivative of carbapenem molecule with the changes in the side chain. It is called a pinum antibiotic. And last comment is, though the Indian guidelines have said that circumcision should be offered, if you look at literature, I believe to prevent UTI, the only way circumcision would help is neonatal circumcision. Circumcision beyond neonatal period, I believe you will have to do 111, I'm quoting literature, 111 circumcisions to prevent one UTI. So I don't think it is going to help. On the other hand, treating vulval synechia with estrogen cream or steroid cream, or if necessary, surgical release, that's a very important measure. These are my quick comments. Brilliant presentation. Learned a lot. Thank you very much.
So just an explanation. Immunocompromised I mentioned because fever without focus in immunocompromised sometimes is UTI where it is missed because there are no other alternative diagnosis and the child kind of sometimes they come with urosepsis or otherwise and they may not have urinary symptoms. So that's why immunocompromised, but not immunocompromised as a cause of UTI.
Yeah, agreed. That's why I said. See, fever without focus, whether it is immunocompromised or immunocompetent, we are going to think of UTI. That point is very well taken. Agreed. But I don't think we should think more of UTI just because a child is immunodeficient. If you look at the causes of frequent infection, the group of UTIs which come, they are all not due to immunocompromised states, but due to a barrier defect or an anatomical defect, or not due to immunodeficiency.
Okay. So, any more questions? Is Bhaskar there or left?
Yes, Bhaskar, I don't think he's there.
Okay, so Dr. Bala, you can conclude.
Yeah, it was a fantastic presentation, and Satish, Vikrant, and of course Pankaj, led by Chitkara. It was a huge success. Thank you very much for the learning opportunity. Thank you all. It was brilliant. Dr. Daruru, if he has any comments, normally he reserves the final word. Dr. Daruru, please.
Sir, you are mute.
Sir, please unmute yourself, sir. Sir, please unmute.
Now I am audible, sir?
Yes, sir.
Yes, sir.
Yes, sir.
It is his brainchild, rather.
Sir, I have been sitting right from the beginning to this end, waiting for the comments to be made and waiting for the comments that the panelists and the presenter has done. There is nothing to be told or nothing to be said. It is excellent. But only one thing is, my observation is that a child who has urinary tract infection, suppose it is of lower type, he goes on handling his genitalia. A male boy who is pulling his scrotum and penis and shrieking with pain and other things has fever, it's a urinary tract infection. Please, we have to work out. Otherwise, nothing I can add to this session. Thank you.
Thank you.
Thank you, sir.
Yes, Manish.
Yes, sir. Thank you very much. Fantastic session, because there are always lots of gray zones in the urinary tract infection, especially ESBL infections and prophylaxis in VUR and all these things. But a lot of things have been clearer today. So thank you very much, Dr. Chitkara sir, Dr. Pankaj sir, and Dr. Vikrant sir, and especially Dr. Satish Pandya sir, from pediatric perspective. Thank you very much, sir, and excellent comment always, Dr. Bala sir, for your guidance. See you everyone again on the next session of this Super 11 in the Link 14 very soon. So good night, everyone, and see you soon.
Thank you so much.
And goodbye.
Thank you.
Thank you.
Thank you. Bye-bye, Chitkara. Bye-bye.
Okay, bye-bye.